Pressure for all?
Well, first of all, I can't believe you're all still sitting here. I can't believe I'm talking here at this point. I get to close the door. I also have to warn you, we're finishing with not an easy talk, so if you're really feeling tired, you got a moment, better go. So we've heard some really good epidemiology. Dr. Aspar's study, I think, gave us a really important additional piece of information. And I'm going to go back to what I like to do is the physiology and the thought behind this. I should have put it down on this, but I didn't. But I have a paper that came out in April of last year in critical care medicine called the highs and lows of blood pressures, which was towards guidelines for how you would do the study to try to answer these questions. So here's the theoretical background, and it'll touch on a lot of the issues today. So if you're in a rush, the standard pressure, no, you can go now, that's my bottom line. Okay, but if you want to stay, now you know the answer, I've given away the end of the book. I'm going to show a few slides that I talked about, that I used on Monday just to orientate you. Blood pressure does not indicate flow. Considered a septic patient, low blood pressure, high cardiac output, or today we can hear, and I certainly agree with this, you can be in shock with a normal pressure, inadequate tissue perfusion. Maximal aerobic exercise, your blood pressure goes only up a little bit, and yet you have a huge rise in cardiac output. Cardiogenic shock, you can have a normal, or as we heard today, elevated blood pressures, actually very commonly elevated blood pressures, and yet low cardiac index. So they don't go together. And I like to think of the overall approach this way, that blood pressure is related to the flow, the cardiac output coming out of the heart, and the systemic vascular resistance. So it's the flow and the resistance that creates the pressure. Remember, it's not the pressure that creates the overall flow. And the output from the heart is dependent upon the cardiac function and the return function, cardiac function, heart rate, stroke volume, and its determinants, and return function, primarily the stress volume and the resistance draining it. And the preload for the heart is also the back pressure for venous return. So as I said in my lecture on Monday, the way our system works, it works like water towers providing a constant pressure load to your domicile. And so you get flow to your apartment or in the hotel by opening up a tap and releasing a pressure source at the top. That pressure source, as I just showed you, was created by the amount of volume you put into the system from the heart per minute and the resistance draining it. That's how you get the filling of these tanks. Now, systemic vascular resistance, I made the more complicated figure last time, but I'll forget the critical closing pressure for it today for simplicity. As you all know, we calculate this as arterial pressure minus venous pressure, and it's 1 over the slope of this relationship. So in this example, going from a mean of 90 to a central venous pressure of 5. What I'm going to do in today's talk is take this apart more, and this is where I think it becomes really important in trying to figure out what to do. So instead of showing the whole resistance, these are going to be theoretical numbers. I'll show you some data for how you can get these at the end. So this shows regional flow now on the y-axis. And it shows, again, the same pressures on the x-axis. And what it's showing now is looking at different beds. Let's say the splanchnic bed, the kidney, the brain, the muscle, the heart. So these are taken out of a textbook, a physiology textbook, showing the flows in each area and then the pressures from them. Now, if I had a fall in cardiac output and no change in resistance, okay, reflexes didn't kick in. So this is a thought process. So this line moves over here, drops, let's say, about 50 or 60. And all these regional flows, of course, will go down because that's the perfusion pressure. So they will all fall. And they'll fall in this example in roughly the same proportion because we haven't changed any distribution of flow. Now on the left is the same concept. So again, that's exactly what I just showed you on the previous slide. On the right, I've just rescaled it. And now, what happens, so just taking the part where it's down, what happens now if I give a vasopressin? Let's say I use phenylephrine. So it restores the blood pressure, but it doesn't really change the cardiac output. And the data for this is a very nice review by Thiel in Anesthesia and Analgesia in 2011, where he reviews all the literature. And there's a few exceptions, but generally phenylephrine does not change cardiac output. So what's happening? So what's happening, you've raised the resistance, but you haven't changed flow anywhere. Now, you guys probably all use it. I use it at times. You have the patient that you've intubated, the pressure drops, you give them a bolus of phenylephrine. What this is called, in my mind, tangible benefits. You feel better, you look up at the monitor, the number's better, but did you change perfusion? What you are hoping is something like this. Let's say you have equal flows through 2 tubes on either side. The blood pressure was decreased, you gave the phenylephrine. You're hoping that it constricted one side and left the side that you wanted, let's say the brain and the heart dilated or not as constricted, and the muscle got constricted. So you're hoping that it preferentially constricted the areas you don't want and went to the ones that you do want. And that probably does occur to some extent because the metabolic activity in those will do that. But how much and when, and as you go to higher doses, do you cut that off? That's the tough question. And I think we saw some evidence of that when we're looking through the trials, like Dr. Asper's trial and the patient who has other ischemic disease where you may see these consequences. So total flow is the same or even lower, the assumption that you've constricted a non-active place. That's what you have to be doing because it's very rare to actually change cardiac output with phenylephrine. The exceptions would be a pregnant woman who has a large blood volume and she can recruit some of that, somebody with spinal shock or alpha blockers or spinal anesthesia and they've lost alpha tone peripherally, that'll work. Hypertrophic cardiomyopathy because you relieve the obstruction. Okay. So let's take it another step. So far, I've treated the regions as a total. Now, I'm going to change the units to per gram of tissue. So on the left side, it's just the total amount to your kidney, to your heart, your muscle. Now it's to 100 grams of tissue. And so the more active tissues are getting more blood. So let's see what that looks like. So now as I redraw these, here is the kidney now showing up really high. So if you look here, the kidney is down here, but now it's dominating. And look, the splanchnic is now much lower because it's a big bed. So per 100 grams, it's not getting as much, but it's getting a lot because there's a lot of it. The muscle is now right down the bottom, even though it's more generous. Where to go? That's the muscle up there. The higher one, because it's a big chunk of your body. So this distribution per gram of tissue is very different. Now, let's see what that implication is. Now, your heart, if you went from 70 beats to 180 beats, that curve would shift like this because the flow would go way up. If you're exercising your muscles, that curve would shift up because it's taking more flow. The point is now, as you lower the arterial pressure, these organ tissues are now getting a decrease in flow according again to their regional resistances. And what becomes evident here is looking at this, look at the heart and the splanchnic, but the one that really gets the hit, one doesn't show it there, let me go back, is the kidney. Because it has a steep line to begin with per gram of tissue, and that's why it takes the early hit, and that's why we saw in the blood pressure studies, if you go lower, yes, it will get hit. Now, there was more renal failure in Dr. Aspar's study, but the mortality didn't change. So, in the really desperate patient, we have to make that kind of decision. Should we be caring about the kidney and deal with it after, or the patient's outcome? Because the outcomes didn't change. Only empiric studies are going to answer that. So this was a study I did years ago, 1986. It was kind of a naive study, but it turns out I guess I had the same idea a long time ago and forgot about it. So what I did in this study, I was interested in these regional resistances. And what I did was a dog study, and I gave them nitroprusside in increasing doses until I got no further fall in blood pressure. So I thought they were maximally vasodilated. And then what I did, I just doubled the dose of nitroprusside to know that I really dilated them. Didn't change, but that was the test. And then what I did, I lowered the blood pressure by just withdrawing blood, and I used radio-labeled microspheres so I could do 4 points and measure the pressure flow lines as I reduced the pressure. So I was able to simultaneously then measure pressure flow lines in multiple regions: the splanchnic bed, the brain, the heart, the kidney, the muscle. And here I'm just showing you the heart and the kidney. And I think it's very illustrative of what happened on the other. So the red line here was the resting state before, and a dog that I did not give. Can't do both in the same dog, they're dead at the end. But in a dog that I did not dilate, so that's the resting pressure flow line, which is very steep in the kidney, as you well know, because that's what it does. It has to filter 20% of your blood volume goes there per minute. When I maximally dilated it, you can see the line here. The important point is there's not a lot of increase. Now compare that to the heart. So the resting heart using the to use the same scale for the heart, you can see at rest it's not taking a lot, but when you dilate it, it has a very large reserve. And what was striking to me when I went back and looked at this data, and I don't think I appreciated initially, I have points shown here that are down in the 12 to 14 millimeter mean pressures, and I'm able to get them, which means this heart is still beating at those kind of pressures. Clearly a dog does not have coronary artery disease, so that's not a problem. But and even what's more striking to me when I look at it, it's still higher, the dilated is still higher than the actual resting state. There was still reserves at that amazingly low pressure, because your heart is designed to handle flows that'll get a cardiac output of 25 liters a minute. So it has huge reserves, as long as you don't put a coronary obstruction in place. Now, let's continue on with that. If all resistance changed proportionally, a lower pressure can maintain that same regional flows. And I am sure that some of the smaller women in the room have a systolic pressure, which is probably in the range of 90 millimeters of mercury. They have no problem walking around, and they're fine. In the paper that I wrote, I had this patient in my office who one time came in, he always has a low pressure. He came in with a systolic pressure of 68 millimeters of mercury. Right arm, left arm, repeated by palpation and by auscultation. He might have some stenoses that I don't hear, but he walks around in the mid-70s. He just, actually for that visit, he just came back from a trip to Los Angeles, to Montreal. So what can happen is this. So if we lower the pressure, but if all the resistances decreased in proportion, and I did this just by stretching my graph, so they were all the same distribution, you could have a pressure of 55 and have perfectly adequate blood flow. And remember, it's blood flow that counts, not the pressure. The pressure is important because of that regional distribution of resistances. You wouldn't be able to get this kind of dilation in the kidney, so it's going to lose. But areas that can, would. Think of your pulmonary circuit. Your total blood flow, 5 liters a minute at rest, goes through your lungs with a mean pressure that's only about 15, 18 millimeters of mercury. No problem, because it's a low resistance bed. So it's the resistance and the distribution of resistances that count. Okay, so the problem with that, though, that's not easy to measure. So one more complicated concept. This is a concept brought up by Krogh, August Krogh from Copenhagen in 1912. And he realized that if you have two areas in parallel, that affects what happens to cardiac output. So here I have a splanchnic bed equivalent and a muscle. So it's called a two-compartment model. When you've heard my other presentations, I have a single bathtub. This is a sink and a bathtub together. And what he showed is when you change the distribution between those two, you change the slope of the venous return curve. And that's because when more flow goes to this muscle bed, the height rises, or the equivalent of pressure rises, and therefore drives more flow back. So we were looking at this in an animal model, looking at the effects of baroreceptors on the regulation of the whole system. And one of the things that becomes apparent, and others have reported this, when you drop the arterial pressure and you trigger the baroreceptors, there's a greater response in the muscle bed than there is in the splanchnic bed. Now what that will do, that will shift the flow to actually the splanchnic bed, and that's shown here. So this is the baroreceptor dropping. So that's the baroreceptor. So we drop the pressure. Here you can see the rise in arterial pressure that you would expect because you've increased resistance. But this unequal change in resistances meant more flow goes to the splanchnic bed than to the peripheral bed. Now that's important because your splanchnic bed takes up volume, and that would actually decrease your cardiac output. It doesn't happen because two interesting things. One, the resistance draining the splanchnic bed actually went down, so the arterial went up, the venous went down. Hard to believe, but that's what we found. And you tighten up the bed, you reduce the capacitance, and all those together will make you recover that way. But the important point, and why I'm showing this, it shows this, and other people have too on the arterial side. There's a greater sensitivity on the arterial side. So what that means is that lower doses of norepinephrine probably, I don't know this for sure, I haven't seen good data to show this, constrict the periphery more than the splanchnic bed. That's okay, because you want to keep your splanchnic bed intact. But as you start increasing that dose, then that specificity may no longer be the case. And eventually you're going to saturate them, and then you're just constricting everything. And it probably overrides local regulatory mechanisms. So there is some value where we're probably producing harm. I don't know how you figure out what that is. And I often wonder whether this is one of the reasons why Jim Russell in the VAST trial found that vasopressin worked, especially in the lower cases. Because the big ones, you've already constricted everything. But in the lower use of patients with the lower levels of norepinephrine, they did better, which was paradoxical. It could be because you still have room to get this differential regulation between the two types of drug. And so he's now getting some more, maybe balanced in the splanchnics, and he doesn't have to use the norepinephrine to do it. Wide speculation. I don't know if that's fact at all, but it's a nice story. The last thing I want to show you, I think it's the last, but just about. Comparing raising pressure with fluids, raising the cardiac output, or raising pressure by vasoconstricting. So if you go from the aorta to the right atrium, and you have this profile through the vasculature, I now give volume and I raise the pressure in the system by raising cardiac output. And as you know, you'll raise it everywhere because the CVP will go up and the arterial pressure goes up, so clearly everything in between had to go up. And there's no reason why without reflexes you would have changed the resistance profile. Now match that increase with norepinephrine. And what will occur is that, again, this is fictional data, but this is likely what will occur, is that when you get down to the capillary level, the pressure may be the same or even lower than it was before. So if you have a leaky capillary state, and you're giving norepinephrine, you may actually reduce the leak because the hydrostatic pressure will be lower at the level of the capillaries. On the other hand, with volume, you're always going to be increasing capillary pressure and always increasing the leak. So I think this might be my last point. Hopefully it is. We're almost out of time. You've been incredibly indulgent. So sometimes volume won't even do it. So this was an example I ran into clinically. It was somebody who's been bleeding and it wasn't recognized by our team, I'm embarrassed to say, but it made for a nice slide. And what this shows is the blood pressure in the middle was progressively going down, pretty nice steep tracing that I got afterwards. And then I come along on the scene, I'm not usually there to be at the initial resuscitation, and I had quite a surprise. So I'm there at the bedside. We quickly give some volume, but I don't want them to give too much because this lady's bleeding. She needs blood. She doesn't need a lot of salt solution. So I'm trying to hold off, and they're all getting excited. And like, what are you doing? The hemoglobin we know has gone from 124 to 68. So we begin our resuscitation, and I've blown it up here. And what this shows is we give a fluid bolus. You can see the CVP increases, but nothing happened to the blood pressure. And I'm looking at this going like, I can't believe this is happening. I know this is a hemorrhagic shock. I've just put some volume back into the system. Why am I not getting a pressure? Probably the heart is now being stunned by this whole thing, and it needs something to give it a kick, a little inotropy. So we give some norepinephrine, the pressure starts rising. Very quickly things turn around, the blood does come, we can quickly come off the norepinephrine, everything's working, and she's fine. But I was shocked initially that the volume just wasn't doing anything. Okay, a standard pressure for all? No. Needs to be condition specific and empirically tested. In septic shock, it's an altered resistance pattern. Initial resistances are low. There could be a greater effect, a decrease in the extremities and more room for different agents because they may be dilating and causing a problem, so maybe that's how norepinephrine is helping initially. And a greater kinetic energy in the process. Hypovolemic, well, peripheral resistance is already high, so you're not going to gain much with a straight vasopressor. Could be greater in the extremities. If it's due to bleeding, as we heard from Dr. Pepe the other day, be careful about increasing the pressure initially, or maybe not, as we heard today. Rupert Pierce. And of course, the real answer is restore the volume. And as I pointed out, sometimes you may need a pressor. Cardiogenic shock, as we heard, I mean, they're squeezed down, and the old line was leave a fed, leave them dead, but you still may need something to maintain coronary perfusion, and use it, but be very careful using it. And think of the local regulators and how those are acting. In sepsis, I suspect the endothelium is not working right, and those regulators are probably not behaving well. So distribution of resistances is critical for the distribution of flow. However, resistances regionally cannot be measured. That's the big limit. And yet we need to know that. So the only way we're going to answer this is with empiric studies to determine the best choices for clinical outcome. And I think these studies are going to have to be determined by the pathological state. Septic patients, cardiogenic state patients, neurogenic, obstructive, hypovolemia. You can't pick one for all. You have to do each of these separately. And even with those, there's a huge heterogeneity, but at least that narrows it down. And I didn't put it on, but I really think there needs to be some flow or a surrogate of flow or metabolism, whether it's a lactate, central venous sat, something to give you an idea that you actually change tissue perfusion, because that is what counts and not a blood pressure. Thank you.